Good afternoon. My name is Dr. Ishai. I'm from the Soroka Medical Center. I'm going to share our 10 years experience in radial artery in cardiac surgery. I have no interest. We have started using the radial artery as in a routine manner since 2006. Since then, we use it for more than 10 years. I have to say that in 2006, it was not very acceptable to use the radial artery as a routine manner. Current evidence suggests that the long-term angiographic patency rate of radial artery is excellent if the target vessel exhibits severe stenosis. Most published series reported better long-term patency for radial artery compared to saphenous vein. And the conclusion from this series of randomized trial and meta-analysis is that radial artery have patency similar to saphenous vein for the first post-operative year, but exhibit significant better patency rate in the mid and the long-term follow-up. Interesting paper that was published in 2012 in the journal from the STS showed that in 2009, just less than 6% of the patient received a radial artery during cardiac surgery. The question is why? The same STS published clinical practice guidelines in 2016, and the section that compare radial artery versus saphenous vein, the conclusion is that the radial artery graft have superior patency versus SVG on 5 years, and they recommend to use the radial artery for significant severe stenosis. Back to our study. Between 2006 and 2016, we operate on 2,370 patients. Actually, we harvested 2,370 radial arteries. Of them, 241 had angiography based on symptoms. In other words, there is a small selective bias. We just took patients that had symptoms direct angiography. The angiography were evaluated by 2 independent observers, and the angiographic outcomes were divided into 4 groups: patent, severe disease, string sign, and total occlusion. Our routines in radial artery harvesting is a pre-op Allen test. In some case, we use pulse oximetry to make sure that the Allen test is positive or negative. In case of peripheral vascular disease, we use Doppler ultrasound to estimate the quality of the radial artery. We always use it as an open manner with harmonic scalpel as a pedicle graft, and we soak it in papaverine. To summarize the study design, we operate on 2,370 patients. We harvest 2,370 radial artery. Of them, 241 had angiography on symptoms base. That create a cohort of 380 distal radial anastomosis. Oops, sorry. And we try to find correlation between comorbidities, graft territory, left side versus right side, target stenosis degree less than 70% and more than 70%, and graft configuration, whether it's better to use it as a free graft or T-graft, and the number of the distal sequential anastomosis, 1 versus 2 versus more than 2. You can see the baseline characteristic of the patient. Again, we are talking about a symptomatic patient. The mean age was 64 years old. Most of them were males. And the interesting part in the comorbidities is that 55% of them were smokers and 46% of them suffered from obesity. Regarding the first question, we found no correlation between comorbidities and radial artery patency. And no correlation was found regarding smoking, diabetes mellitus, or PVD. We found that radial artery patency in males was much better, significantly, statistically better compared to radial artery in females. Regarding left side versus right side, as you can see, 177 anastomosis were to the right side, of them almost 72% to the PDA, where 200 to the left side, and most of them to the first marginal or second marginal. And we found no significant difference between right versus left. Again, most of the anastomosis were to the PDA in the right side of the heart. The third question, I don't know whether to say unfortunately or thanks God, but just 70 anastomosis were grafted, less than significant stenosis. In other words, the sample size was too small to make any conclusion, but as you can see, just 2 anastomosis were normal. In 5 cases, we had stream sign, and 10 cases, the grafts were occluded. Regarding the question whether a free graft or T graft, we found that free grafts, radial artery free graft, are better than T graft, and it's significantly, statistically significant. The next question was whether the number of distal anastomosis make any difference. We divided the grafts, the groups, the 2 groups. The first one, 2 or less sequential anastomosis, and the other one is more than 2, and we found that 2 or less graft was better compared to more than 2. A subdivision of this question, we ask whether the difference is because of the T graft or the free graft, so we check just the free graft, and we ask the question whether 1 anastomosis is better than 2, and there was no significant difference. In other words, there was no difference between 1 or 2 when we are talking about free graft. And the overall patency rate for the free graft in our series, again, symptoms direct angiography, was 79.8, which is pretty good. To summarize the result, radial artery patency was better in males, was better as a free graft, and when we constructed 2 or less sequential anastomosis. I'm going to do a careful extrapolation. The overall radial harvesting was 2,370. In other words, just 10% of our patients underwent angiography post-operation. And when we do, again, a careful extrapolate to clinical outcomes, it seems that 97% of our patients had uneventful clinical outcome. And the conclusion are that long-term angiographic patency rate of radial artery graft is excellent. The patency is better for males for significant target. I mean, less stenosis of more than 70% as a free graft, and when no more than 2 sequential anastomoses are constructed. Thank you.
Yes.
So, Norman Laporte from Los Angeles. So, we've actually studied this using coronary CT. And our results are very similar to what you're seeing. Is very, very high patency rates, similar to the mammary. But why do you think it's being underused? Why do you think the radial artery graft is being underused so much? Certainly, I think less here than in the United States.
Well, I did my fellowship in Toronto with Dr. Frims, which is kind of a mentor for radial artery, and we use much more radial artery here compared to Toronto. I think surgeon fears to change their routines. The vein is good enough, is long enough, and you have no problem to reach any territories. The radial artery is very reactive, it can be spastic, it cannot, compete competitive flow, so that are the main reason. And you need some balls.